Imagine undergoing a painful, invasive, like permanent surgery to alter your body. You go through the anesthesia, the brutal recovery, the physical toll, only to finally look in the mirror and realize that the profound pain you were trying to cut away is, well, it's still entirely in your head.
Yeah, the underlying trauma hasn't been touched at all. But now, you have physical scarring on top of it. It's a horrifying realization, yet, it happens far more often than we'd like to admit in modern medicine.
Which is just terrifying. And that scenario is exactly what we're focusing on today. Welcome to this deep dive where we're going through a stack of clinical guidelines, ethical standards from the World Association for Sexual Health, and some really striking case studies.
We really are.
Yeah.
And the mission here is to uncover this massive ethical minefield in medicine. Specifically, what happens when patients seek a physical, surgical quick fix for deep psychological or sexual trauma.
Right, because understanding these specific medical ethics, it totally changes how you, as a listener and frankly as a potential patient, view the entire connection between your mind and your body in healthcare.
Absolutely, because we are fighting a very dangerous, incredibly widespread myth here. This idea that a scalpel can fix intimacy. Our culture constantly reinforces this notion that altering your physical shell will automatically cure a profound psychological wound.
But treating a psychological issue with a surgical tool doesn't just fail. The sources we're looking at show it can lead to devastating, totally irreversible outcomes.
It really can. Just looking at the clinical guidelines from ACOG, the American College of Obstetricians and Gynecologists, they are incredibly firm on this, especially regarding female genital cosmetic surgery, or FGCS.
Which is becoming so common, right?
Exactly. But their literature states unequivocally that current evidence does not support the idea that cosmetic surgery will improve body image or libido or sexual satisfaction.
So people are walking into clinics fully believing that changing their physical appearance will magically fix how they feel about themselves during sex?
They are. But the data simply doesn't back that up.
Mm.
And, the stakes become astronomical when we introduce underlying psychiatric condition.
Oh, sure. Like what?
Well, consider a patient with body dysmorphic disorder, or BDD. This is where they have a severe preoccupation with a completely imagined physical defect, or they're obsessing over a microscopic, completely normal variation in their body.
Wow. Okay. So if a surgeon operates on that patient, they aren't treating a real physical defect at all.
Not even a little. They're operating on a perception. The medical community actually considers performing cosmetic surgery on a patient whose core issue is body dysmorphic disorder to be essentially colluding with a psychiatric disorder.
Colluding, that's a strong word.
It is, but it's accurate. You are validating their delusion that their body is broken. A scalpel cannot cut out an obsession.
God, that makes so much sense. And the case studies in our stack for this deep dive, they are honestly heartbreaking to read.
They really are tough.
There are these detailed accounts of women who underwent voluntary cosmetic labiaplasty, specifically requesting to alter the appearance of their genitals. And they later experienced this profound, crushing regret.
Yeah, reporting that they felt mutilated.
Exactly. Some even looked back at photos of their pre-surgery bodies and suddenly realized they were perfectly normal to begin with.
And when clinicians dig into those specific cases of severe post-operative regret, this really tragic pattern emerges. These patients frequently have an undiagnosed history of sexual violence or severe post-traumatic stress disorder.
Right. The surgery was basically a desperate attempt to treat trauma and severely low self-esteem. They felt broken by an experience, and they tried to fix it by physically altering the body part associated with that trauma.
Which is completely understandable from a psychological standpoint, but surgically disastrous.
Okay, let's unpack this with an analogy. Performing cosmetic surgery to fix complex psychosexual trauma is basically like putting a fresh coat of paint on a house with a crumbling foundation.
Oh, that's a great way to look at it.
Right. You haven't fixed the house at all. You've just masked the structural damage. The walls are still going to collapse, but now they look slightly nicer from the outside while they fall apart.
What's fascinating here is how that house analogy illustrates a massive violation of core medical ethics. The foundational principles of medicine are beneficence, which means acting in the patient's absolute best interest, and non-maleficence, which is doing no harm.
So performing an irreversible tissue repair on a patient whose distress is rooted in trauma, like a crumbling foundation, that's the complete opposite of beneficence. You aren't treating the root cause.
Exactly. And worse, you are actively violating non-maleficence because every surgery carries physical risks, right?
Like scarring or nerve damage.
Scarring, nerve damage, chronic pain, infection. if you subject a traumatized patient to those physical risks without actually addressing their trauma, the resulting physical complications will drastically exacerbate their psychological distress. So the medical community bears this strict ethical duty to dig much deeper than the surface level request.
Yep, but it's easy to say do no harm in theory, but when a deeply distressed patient is sitting in your office practically begging for surgery, theory isn't enough, is it?
No, it's not. Doctors needed an actual mechanism to stop themselves from operating. The medical field has had to build these strict ethical guardrails to force clinicians to separate mechanical fixes from psychosexual realities.
Right, because the risk of masking trauma is so catastrophic. The sources talk about organizations like the Royal College of Obstetricians and Gynecologists, RCOG, and the International Society for the Study of Vulvovaginal Disease.
ISSVD.
They issue these blaring warnings about cosmetic procedures lacking clear medical indications. Like, clinicians are ethically required to draw a hard, bold line between what is purely cosmetic and what is actually medically indicated.
Right, and medically indicated would be treating something like dyspareunia, which is severe physical pain during sexual intercourse, or preparing structural tearing from childbirth.
Which is a universe away from a patient desiring an aesthetic change just because they're comparing themselves to digitally altered, heavily filtered images online.
A completely different universe.
Yeah.
And to navigate that massive gap, the guidelines mandate practical consent checklists.
And we aren't talking about just handing a patient a clipboard with dense legal jargon, are we?
No, not at all. Ethically, doctors are required to look the patient in the eye and explicitly explain the limitations of the current medical evidence. They have to actively clarify the cosmetic versus medical goals.
They also have to discuss the high variability in outcomes, right? Like, a surgeon literally cannot guarantee you will heal perfectly symmetrically or that you won't lose sensation.
Which is huge. Losing sensation in a procedure designed to make you feel better sexually is a massive risk. The guidelines emphasize that psychological counseling and competency assessments must happen before a scalpel is even prepped.
Okay, I have to pause and push back on this,
Sure, go ahead.
because I'm getting stuck on the logistics here. A surgeon gets maybe 15 minutes with the patient during a standard clinical consult. How on earth are they supposed to uncover deeply repressed sexual trauma, diagnose body dysmorphia, and untangle these complex psychosexual red flags in the time it takes to check someone's blood pressure?
If we connect this to the bigger picture, that is the ultimate tension in modern medicine right now, and it is driving a complete paradigm shift.
That shift towards what?
Medicine is moving rapidly toward a biopsychosocial model of care. You can no longer look at a patient purely as biological tissue. The biology, the psychology, and the social environment that mind exists in, they are an inseparable web. You just cannot ethically treat the tissue without evaluating the mind.
But practically, how does a time-crunched doctor manage that? Like, on a Tuesday afternoon?
Well, our sources actually point to a very specific high-stakes area of sexual medicine to answer this. Penile prostheses.
Oh, okay.
Yeah, this is an arena where managing patient expectations isn't just a polite recommendation. It is a formalized, absolute ethical mandate.
Right, because the gold standard treatment for erectile dysfunction that no longer responds to medication is the surgical implantation of a penile prosthesis. It's a highly effective biological fix.
It is. But the medical literature warns that the success of this surgery relies almost entirely on shared decision-making and, honestly, ruthless expectation setting beforehand.
Because unrealistic expectations are a massive ethical hurdle. Patients must be explicitly told, before they ever reach the operating room, that the implant will not recover any lost penile length.
Yes, and counterintuitively, they might actually perceive their penis as shorter post-surgery.
Wait, they think it's smaller after the surgery?
Often, yes. So if a patient goes into that procedure secretly expecting to regain the body and the sexual stamina they had in their 20s, the biological surgery might be a flawless technical success, but it will be a catastrophic medical failure.
Yeah, because the patient will be devastated. Their relationship might suffer. Their psychological state will just plummet.
Exactly. So to prevent that kind of medical malpractice and psychological harm, clinicians utilize a highly practical screening tool designed specifically for those fast-paced 15-minute consults.
Right. This is the patient mnemonic called CURSED, C-U-R-S-E-D. It helps them quickly identify high-risk psychological traits.
Let's break down those traits, because they highlight the exact psychological red flags surgeons are hunting for. The C stands for compulsive or obsessive traits.
So this is the patient hyperfixating on microscopic asymmetries that literally no one else can see.
Spot on. Then the U is unrealistic expectations. Like the patient expecting a prosthesis to suddenly save their failing marriage.
Yeah, that's not going to happen. Then we have R for revision seeking. These are patients who just had a procedure 6 months ago and are already back in the office demanding it be tweaked or entirely redone.
Right. The S is a massive one. Surgeon shopping.
Mm.
The patient has been to 4 different doctors who all refuse to operate, and now they're in your office looking for the one surgeon who will finally just say yes.
Here's where it gets really interesting to me. The rest of the acronym is E for entitled, D for denial, and the final P, breaking the acronym, just slightly stands for psychiatric disorders.
It's a very comprehensive list.
I love looking at this list because it completely reframes human behavior. Think about surgeon shopping or acting entitled. In literally any retail environment, that's just a tough customer. The customer is always right.
Sure, in a store.
Right. But in reconstructive sexual surgery, treating a demanding patient like a VIP retail customer is a fast track to a medical catastrophe.
Oh, absolutely. A 5th surgeon looking at a patient who has been turned away 4 times isn't looking at a persistent consumer. They are staring at a flashing neon sign for body dysmorphia or severe trauma.
Wow.
Identifying the cursed patient forces the clinician to stop, step back, and recognize that proceeding with a physical intervention will actively exacerbate an underlying psychosexual crisis.
The ethical rule of thumb written into the expectation management guidelines for these surgeries is literally undersell and overdeliver.
Which is such a contrast with how cosmetic procedures are marketed on social media, right?
Yeah.
Where they completely oversell perfection and entirely downplay the risks. That tension is where the ethics get constantly tested.
So what does this all mean when we hit a wall? Let's say a doctor uses the cursed mnemonic or the consent checklists and realizes this patient sitting in front of them definitely has complex psychosexual dysfunction.
Okay.
A biological tissue repair is ethically ruled out. What happens next? You don't just deny the surgery, pat them on the back, and send them out the door to suffer alone, right?
No, of course not.
Yeah.
Abandoning the patient violates the very ethics we just established. You have to shift the treatment paradigm. Clinicians need structured frameworks to actually treat the root of the problem.
And one of the most effective tools for this in the sources is the PLISSIT model.
Yes, PLISSIT. It's a tiered, ethical approach to treating sexual health issues without overwhelming the patient.
Let's walk through how this actually works in a room. The first tier is P for permission.
Right. Before you can treat trauma, you have to create a radically safe, non-judgmental space. Permission means the doctor is proactively signaling to the patient that it's okay to talk about sex or pain or trauma. Normalizing the conversation is the foundational step.
Because if they don't feel safe, they won't say a word. Once that door is open, you move to LI for limited information.
This involves providing targeted, factual education to dispel myths. Say a patient is terrified because they think their physical pain during intimacy means they're permanently broken.
Which happens a lot.
A lot. The doctor provides limited, specific anatomical or physiological information to relieve that immediate anxiety. Just the facts they need right then.
Then we step up to SS for specific suggestions.
This moves from education to action. The clinician might suggest practical behavioral exercises. A really common one is sensate focus exercises for a couple.
What does that look like?
It's a structured way to touch and connect that removes the goal of intercourse entirely, which dramatically reduces performance anxiety and helps rebuild intimacy safely.
Okay, that makes sense. And the final tier is IT, intensive therapy.
Right. If those first 3 tiers don't resolve the issue, it's a clear signal that the patient needs specialized help. The doctor ethically refers them out to a sex therapist, a trauma specialist, or a psychiatrist to deal with complex relationship dynamics or severe repressed trauma.
So what does this all mean in practice? The PLISSIT model is essentially a staircase. You cannot safely leap to the top floor and jump straight into intensive therapy, let alone invasive surgery, without first building the ground floor.
No, you'd completely overwhelm them.
If you don't give the patient permission to safely discuss their realities, you will never find out about the trauma driving their request for a scalpel in the first place.
Exactly. And to help clinicians build that ground floor efficiently, they use another framework from our sources called the 5 Ps. It's a standardized method for taking a sexual history that ethically shifts the entire focus away from stigmatizing labels.
Because asking someone to label their identity or categorize their desires can instantly trigger shame and just shut down all communication.
Completely. So the 5 Ps focus strictly on objective behaviors. The doctor asks about partners, practices, protection from STIs, past history, and pregnancy plans.
So by focusing on what a patient does, rather than forcing them into a box of who they are, the clinician protects the patient's dignity.
And the byproduct of that respect is drastically more accurate medical information. Removing the judgment removes the barrier to the truth.
Which is so critical. And all of this reveals an ultimate ethical necessity in modern healthcare, which is interdisciplinary sexual medicine. Because no single doctor, no matter how brilliant they are, can know everything.
They just can't. The literature frequently describes the extreme danger of what they call epistemic blind spot.
Epistemic blind spot.
Yeah, if you only ever evaluate a patient through a single, highly specialized medical lens, you will miss crucial parts of the broader picture. A surgeon sees a surgical problem. A psychologist sees a psychological problem.
Right. You have a blind spot based entirely on your specific training.
Exactly. So ethical care requires a team to cover those blind spots.
Yeah.
One of the most fascinating examples from our sources involves a pelvic floor physical therapist.
Oh, I remember reading this part.
Imagine a patient suffering from chronic pelvic muscle spasms. A purely mechanical, single-lens view would dictate that the therapist should just aggressively stretch the muscle.
Just treat the hardware glitch. Force it to relax.
But an interdisciplinary, trauma-informed physical therapist recognizes that those specific muscle spasms might actually be a profound trauma response. The body is in a state of hypervigilance. The muscles are literally physically guarding against a perceived danger because of past trauma.
Wow. And you cannot stretch a psychological trauma response out of a muscle.
You really can't. The physical therapist realizes they have hit an epistemic blind spot. They don't just keep pushing and causing more pain. They collaborate with the psychologist. They treat the mind and the body simultaneously.
This raises an important question, though. How do all these specific frameworks, the Plisset model, the 5Ps, building these interdisciplinary teams, how does that actually connect back to the core ethics of medicine we talked about at the very beginning?
Well, they are the living, practical application of those ethics. The World Association for Sexual Health, or WAS, lays out these guiding principles demanding science-based, holistic practice.
Right.
By using these frameworks, clinicians are actively protecting patient autonomy. They arm patients with the actual truth so they can make informed decisions. And they protect patient dignity by refusing to treat them as, malfunctioning biological machines.
It is a massive, incredibly vital shift in how we view healthcare. I mean, we started this deep dive looking at the murky, often dangerous line between biological tissue repair and complex psychosexual dysfunction. And the biggest takeaway here is that biological tissue repair, the scalpel, the implant, the cosmetic alteration, is just one highly specialized tool.
And in cases involving trauma or dysmorphia, it is almost always the wrong tool.
Medical ethics now demand that clinicians look at the whole person. They are required to use checklists to manage expectations. They have to scour consults for those cursed patient red flags. And they rely on tiered frameworks like the Plisset model to ensure that a physical fix never masks deep psychosexual trauma.
It forces the medical system to ensure the treatment actually matches the root cause of the suffering, rather than just treating the symptom the patient happens to point to.
And understanding these ethical guardrails isn't just some academic exercise for medical students. It directly empowers you as a patient. Knowing that these frameworks exist gives you the vocabulary to advocate for yourself.
Absolutely.
It ensures that any healthcare provider you see treats your mind and your body as a deeply connected, inseparable ecosystem, not just a mechanical problem waiting to be solved on an operating table.
Because the ultimate medical irony is that a flawless biological surgery can be a catastrophic medical failure if the mind isn't treated alongside the body. We've seen how strict ethical guidelines are evolving in sexual medicine to treat the biopsychosocial unit. But think about the rest of the hospital for a second. How might these exact same interdisciplinary, trauma-informed principles completely revolutionize other areas of purely mechanical medicine?
Oh, wow. Think about orthopedics or cardiology or gastroenterology.
Exactly. What if a patient's chronic knee pain or heart palpitations or severe digestive issues are also carrying the immense physical weight of psychological trauma?
If we stop looking for the jagged white line on the X-ray in every single medical field and start treating the whole person, how much more effective could all of medicine become?
It really makes you wonder.
It turns out admitting the X-ray machine is broken might just be the most healing thing a doctor can actually do.